In this video, we will demonstrate cataract surgery in a posterior polar cataract. What we can see is a central small posterior polar cataract in a young patient in which a posterior capsular excess is initiated, and we take care that we have an adequately sized capsular excess. Here with a digital marker, we are aiming at 5.5 millimeter anterior capsular excess. This patient had opted for a premium IOL, which is a EDOF toric IOL. So we have to take care that lens is implanted in the bag even if there is a posterior capsular rent. After the main port is made, we were very careful to have a very gentle hydrodelineation. In posterior polar cataract, we have to avoid hydrodissection that would lead to a premature rupture of the posterior capsule. So what you can see here is a golden ring appearance, which is typical after hydrodelineation. And then, since the patient was young, it's mainly a cortical matter, or is a very soft nucleus, which was aspirated using a phaco probe, and the central core is sucked in this. And then you go to the epinucleus part, in which you have to be very careful, because there, when the posterior polar cataract is adherent to the posterior capsule, and a turbulence in the anterior chamber may lead to the posterior capsule giving way. So whenever you come out with the phaco probe, you have to first inject viscoelastic and then come out. Next comes the hydrodissection part, and the peripheral cortex is aspirated first, and last we go to the central portion, so that if the posterior capsular tear occurs, then the most of the cortical matter is out by then. And as you can see here, once we are going to aspirate the central part of the cortical matter, you can already visualize a posterior capsular rent, which is linear in nature. And very carefully we remove all the cortical matter. Even the last portion, we have to be careful that it doesn't fall back in the vitreous cavity. And we didn't remove the irrigation port, because that will lead to vitreous prolapse. When the lens is being implanted in the bag, we have to be very careful to avoid any vitreous disturbance, and the leading haptic here goes into the bag. After that, we very gently push the trailing haptic in the bag and align the lens as per the digital marker. And what you see here is a very gentle manipulation of the lens, so that the 3 dots of the toric IOL is aligned with the digital marker. And after this, to avoid turbulence in the AC, we didn't do irrigation aspiration, just wash the viscoelastic in AC using infusion cannula. And finally, a pilocarpine was used to bring down the pupil size, so that we are sure that there is no vitreous in the anterior chamber. The gentle hydrodissection of the wounds was done. And for extra precaution, a small air bubble was injected in the anterior capsule. Thank you so much.